CD33 is expressed in about 90% of AML patients, and that certainly makes it a promising target. So to talk about a new agent that does just that, I am back with Dr. Anjali Advani, who is an MD and director of the Inpatient Leukemia Program at the Taussig Cancer Institute and associate professor in the Cleveland Clinic Lerner College of Medicine, of course, Case Western Reserve University, and you were the senior author on this abstract. First off, thank you again. We talked in Chicago about treating older patients, and again, we're back in the setting of older patients. This time the disease is a little different, CD33 positive acute myeloid leukemia. Tell us about the agent you're investigating here.
Sure. So SGN33A, the other name for the drug is Vadastuximab Talirine, so we'll talk about it as
You notice I had you pronounce that rather than me.
So we'll talk about it as SGN33A.
Good, thank you.
So basically, it's an antibody-drug conjugate. And so CD33 is expressed almost uniformly on AML cells. And in this case, the antibody, anti-CD33, is linked through a very stable linker to a chemotherapy, which is a PPD dimer. And that dimer is basically able to, once the drug is internalized into the leukemia cells, that dimer attaches to the DNA within the leukemia cell and basically leads to cell death. And so the thoughts have been that this drug may be a little bit better than some of the other previous drugs because it has this very stable linker. And so that allows it to be very stable in circulation. And then hopefully it doesn't have a lot of off-target toxicity because of the fact it's an antibody-drug conjugate.
So tell me about the patients. Describe them a little bit.
So in the study, the patients that were eligible to go on, basically they did have a good ECOG performance status, but they needed to be deemed either ineligible to receive high-dose chemotherapy by the physician, or the patients may have declined intensive chemotherapy. So in this older age group, because the prognosis with intensive chemotherapy is poor, some patients will also decide not to undergo intensive chemotherapy.
Makes perfect sense. So this was a dose escalation study. How many patients did you look at and what did you find?
So in this particular part of the study, so there was the phase 1 dose escalation, which we previously talked about. In this study that we're presenting at ASH, we basically looked at the expansion cohort, which was about 27 patients. And these patients were all treated with the 40 mics per kg dosing as a single agent. And then the question was, in these older treatment-naive patients, how effective was the drug as a single agent?
So how effective was it?
So more than 50% of patients, so about 58% of patients achieved either a CR or a CRI, which means that they had a remission with less than 5% blasts, but not complete count recovery either of neutrophils or platelets. So that does not include the patients that were what we consider leukemia-free state, which would be without recovery of either.
Now, interestingly, most remissions were achieved after one cycle. And these were in patients with adverse risk features, to say the least.
Correct. And so I think that's really encouraging. So again, the numbers were small because this was an expansion cohort. But I think the really encouraging thing was even in patients that had adverse cytogenetics or that were FLT3, those patients also seemed to do just as well, or patients that had an antecedent hematologic disorder, such as myelodysplastic syndrome.
So the safety or adverse events, that was about it?
So the main thing in terms of safety and toxicity really was the hematologic toxicity, which would be expected. So most grade 3 and grade 4 events were really hematologic and would be expected with treating this disease population. There were 2 dose-limiting toxicities. One was a case of hematuria that occurred in the setting of a patient that had low platelets. And the second was there was one incidence of a patient that had a decreased DLCO. So in the initial animal models, there was a concern about pulmonary toxicity. It turns out the patient in this study that had the pulmonary toxicity had a lot of comorbidities, and this occurred in the setting of heart failure, and their DLCO actually went back to baseline. So we think that the DLCO was not really drug-related, but obviously something we had to monitor very carefully.
Now, based on your results, where would it make sense to further explore this agent?
That's really a great question, and kind of where the new studies are going. So the activity was very, very high. I think the notable thing is that the remissions were short-lived as a single agent. And so another abstract that's going to be presented by my colleague, Dr. Fati, is looking at CD33A, SGN33A in combination with hypomethylating agent, so either decitabine or Vidasa. So that for older patients is kind of the next avenue, and there's going to be a randomized study called Cascade that is going to be looking at basically Vidasa versus Vidasa plus SGN33A. So I think that's a really exciting study. So the question is whether in patients that are not good candidates for intensive therapy, if you add SGN33A to hypomethylating agent therapy, will that improve outcomes?
Right.
And then the second part is going to be in the younger patients with newly diagnosed AML. There is a study that should be opening very soon looking at adding it during induction. So there was a study that is going to also be presented here looking at adding it during induction, consolidation, and maintenance. So I think it's very active as a single agent, but probably to get good relapse-free and overall survival,
right,
you really need to combine it and try to sort out the best way to do that.
And maybe like in the pre- and post-transplant period? Is that
That's a great question. That's another area that that they are actually actively investigating. So that's a great question. So one of the really potential good avenues would be to look at it as, for example, get it as a bridge to transplant. So because it has a high remission rate in a younger patient that's had a lot of chemotherapy, using it to get them in remission and then get them onto transplant.
So are you kind of optimistic?
Absolutely, absolutely. I think it's really exciting. I think the question is going to be really kind of how to move it forward and how to really improve. So the other thing that Dr. Fati will present that's really fascinating is in those patients where they treated them with hypomethylating agent plus SGN33A, if they achieved MRD negativity, those patients did extremely well.
Oh, nice.
That data in the single agent cohort didn't really pan out, but again, I think it's probably because it was as a single agent. So again, I think that's another avenue. And then, there are a lot of other things that are coming out. So I think ultimately trying to figure out the way to best position it in combination is going to be the way to go.
There is a lot of news coming out of ASH 2016. Please check ASH Clinical News, both online and, of course, in print. For ASH Clinical News, I'm Rick McGuire.